So obviously endometrial hyperplasia can be a very large topic, and then we have about 20-25 minutes to talk about it. So I thought we would go through 3 commonly encountered scenarios in the context of hyperplasia, review the risk factors to better understand the appropriateness of testing and referral, and then to discuss some treatment strategies. Just some housekeeping. None of these industries would influence this talk in any way. So first case is a 62-year-old gravida 2, para 2. She's asymptomatic, and in tamoxifen use, sometimes the lining gets thickened, and so the family physician decided to screen her. She's had no bleeding, past history of tamoxifen use from age 45 to 55 for hormone receptor positive breast cancer. She's otherwise healthy, and an ultrasound scan was performed, and the lining is now 11 millimeters. So what should we do? It's kind of outside the normal. Should we biopsy her? Should we do further imaging with the sonohistogram or MRI? It's just a poor study where the radiologist has not given you details about vascularity, inhomogeneity, fluid. Should we treat? Should we refer to a gyne-oncologist? What should we do? So this is our guidelines from 2010. They're a bit dated, and we're about to update it for 2017, 2018. And obviously, transvaginal ultrasound should not be used as a screening test for endometrial cancer. And endometrial sampling in postmenopausal bleeding really should not be routinely performed. So indications for the greater than 5 millimeters or 6 millimeters or more that we often use as a criteria for these women should not necessarily apply to the asymptomatic woman. And a woman who has other findings, such as the nuances of the fluid or vascularity, those are the ones that may be considered for further investigation. And Vuento did a study, 2 studies that were published in the British Journal of ONG with over 1,000 women screened. And we see thickness in 3 to 17% of menopausal women, but only 1.3 to 1.7 per thousand will truly have a cancer. What about the cutoff? There are some studies that show around 14 millimeters. Now the positive and negative predictive values are much more significant. So should that be an arbitrary cutoff? I think the evidence sort of suggests more than 14 we should investigate. Between 11 and 14, based on other criteria such as fluid, vascularity, then you can consider investigating. How about polyps? What if there's a polyp in this patient? The prevalence is 13 to 50%. But hyperplastic with atypical polyps can occur in up to 2% of cases in cancer and 3.5% of cases. And polyps are a known risk factor for things progressing into cancer. So they ordered a sonohistogram. The lining was 6 millimeters, and they found 2 polyps. So now what? Do we refer? Do we biopsy? And did this investigation really change your management? And this is part of the point here, that this woman has now undergone several testing, and we started a map of discomfort. So decisions about further investigation should be made on a case-by-case basis according to our guidelines. And the tamoxifen question, I think, has been borne out that we should not screen these women on tamoxifen with ultrasound scan, and they should really only be investigated if there's abnormal bleeding. And not all postmenopausal women with polyps should necessarily undergo treatment. So what are some risk factors surrounding this case? So hormone therapy, presumably combined if she still has her uterus. The evidence does demonstrate that it shows increased thickness, but not cancer. In fact, the WHI study showed a reduction in endometrial cancer, but it was not statistically significant. Elevated BMI, so greater than 26. Hypertension and antihypertensive therapy. This is all based on a 10-year study of 600 women in the 90s. If we look at tamoxifen use, there is certainly a greater risk of endometrial cancer, about 1.5% on average, and it's augmented if they've been taking hormone therapy as well. Endometrial thickness can be confused with stromal hypertrophy, so tamoxifen causes a subendometrial hyperplasia, so you have a false positive on your result. And if there's pre-existing lesions, they're a greater risk of developing an atypical process. And AGHOG did finally come down with the recommendation that any woman who's starting on tamoxifen should be screened first for anything in the lining, and it should be taken care of by a gynecologist before placing them on tamoxifen. What we do see in women who are on tamoxifen, there's a progressive and annual increase in the thickness up to 3/4 of a millimeter per year. And even after 5 years of use, the range can be up to 6 to 21 millimeters. And after discontinuation, we see a regression about 1.25 millimeters per year. And these were prospective studies. So what about polyps? Most of them are benign, 97% are benign. About 1.2% are hyperplastic with atypia, and 1.9% are malignant. And if we look at finding polyps on sono or ultrasound in the context of risk factors, risk factor greater, a BMI greater than 30, diabetes, menopause, and age greater than 60 were all found to be significant risk factors, and this was a retrospective study by Gregoriou of 516 patients. So the biopsy was done by the referring gynecologist. Naturally, it was insufficient. So a sauna histogram demonstrated polyps and otherwise thin lining. So she was taken to a hysteroscopy, so this is now her third investigation for this. So she underwent hysteroscopic polypectomy, and this is just using a device which I'll come back to a little bit later in the ambulatory discussion. And fortunately, this is a MyoSure device that you'll see. And fortunately, the pathology was benign. She was discharged back to her family doctor, and no further surveillance or imaging was required. So should this woman have been screened? So what are the costs of screening? An interesting Australian study looked at 35 patients with a rate of endometrial cancer in one of them, so about 3%. So obviously a very small study, but the cost for finding one cancer was almost $500,000 Australian dollars, and about 11.6 complications for finding out one cancer if we were to stratify those risks. So it's not a benign study that we start this patient on because they undergo a lot of tests and investigations. How about endometrial biopsy? Failed due to stenosis and pain. So obviously our menopausal woman, the cervix can be narrower, she's got vaginal atrophy, and in the end it was insufficient, but we put her through that examination. The false negative rate can be in 5 to 15% just in global thickening, but if we look at focal findings, it can be as high as 83%. So it's a very poorly predictive study. And obviously, if we look at self-reported discomfort, pain, and bleeding, 16 to 30%, and I would argue if it was asked of all of our patients, I would say probably 100% of them would have experienced pain or discomfort. DNC, which is our traditional gold standard, false negative rate of 2 to 6%. And again, in the context of a focal finding like a polyp or thickness, it can be as high as 60%. So the question is, should we have proceeded directly with hysteroscopy in these patients? And this is a study looking at about 190 patients. So it is certainly more accurate in terms of detecting endometrial hyperplasia with guided biopsy. Diagnostic hysteroscopy and blind biopsy, where you look inside, you do a curette and look inside again, has a similar false negative rate as a DNC, and obviously incomplete removal of a polyp in about 4% of cases with recurrence. So what is endometrial hyperplasia? So characterized by proliferation of endometrial glands of irregular size and shape compared to normal proliferative endometrium, an increase in the gland to stroma ratio, and virtually always results from chronic estrogen stimulation, unopposed by the counterbalancing effects of progesterone. So we've come from this more complicated sort of strata for hyperplasia: simple without atypia, complex without atypia, simple atypia with hyperplasia, and complex atypical hyperplasia. And this terminology must be abandoned, and I think we have to put the onus on our pathologists to also give us good results. And in 2014, the WHO sort of really stratified it into two broad categories. And why did they do that? So if we look at hyperplasia without atypia, the relative risk ratio is unchanged from the general population. So regardless of hyperplasia, the common practice that we all used to do is treat hyperplasia because I think we believed in the former paradigm that hyperplasia becomes atypia and then atypia becomes cancer, and that's borne out to not be true. And then obviously atypical hyperplasia has a relative risk ratio of anywhere from 14 to 45, so quite significant. And coexisting cancer can be as high as 60%, so very important to understand that these patients may already have a coexisting cancer in half or more. So if we look at hormone factors itself, unopposed estrogen therapy, certainly a risk factor. Combined hormone therapy like the WHI may be protective. Extended oral contraceptive use has a risk reduction even 10 years after stopping. The total number of menstrual cycles, or early menarche, late menopause, or interruptions of menstruation are protective, such as pregnancy, breastfeeding, or contraceptives. Pregnancy is protective. Infertility and its associated treatments can be a risk factor, along with obesity, tamoxifen therapy, rare tumors like stromal cell tumors, and then PCOS, which we're seeing more and more. So if we look at non-hormone risk factors, even use of a copper IUD has been shown to reduce risk factors. I think the data on the levonorgestrel IUS is still pending, but we presume that it will also be protective. Age, a fatty, high-caloric diet by itself is an independent risk factor. Diabetes, I think this is a category that we're seeing more and more of, the hereditary non-polyposis colon cancer and the Lynch syndrome patients. They can have a risk factor of up to 40 to 60% of having coexisting endometrial cancer. If they personally had a history of breast ovarian cancer or prior pelvic radiation, mainly to DNA cell damage. So this is my next case, a 37-year-old with infertility, trying to conceive for the last year and a quarter. She's had irregular cycles. Her BMI is elevated at 28. She's had impaired glucose tolerance. She's got central adiposity, mild acanthosis nigricans, and minimal hirsutism. Normal blood work except for an elevated testosterone, high LH to FSH ratio, and a fasting glucose. So ultrasound scan was done. We see polycystic ovaries, a very thick endometrium, about 19 millimeters. She's referred to an infertility clinic without seeing a general gynecologist. And the biopsy that they did shows atypical hyperplasia. She's 37 and wants to get pregnant, so now what? So are there acceptable limits for the premenopausal patient? And the truth is there's no good data, but I think based on my review of literature, this is acceptable in terms of the predictive value. So 4 to 8 millimeters in the proliferative phase, and again 8 to 14 in the secretory phase. So in the fertility context, she already had a concurrence on a histogram and then revealed a very large polyp. So what are our management options for this young person? Conservative versus definitive. Fertility is obviously desired. And if we look again at definitive diagnosis with an endometrial biopsy, we have that concern about a 59% chance of a coexisting invasive cancer and that risk of a 14 to 45 relative risk of progressing to an invasive cancer. Obviously, she was taken to a hysteroscopic polypectomy. So the final pathology, this is the polyp here that was shaved off. And unfortunately, did show atypical hyperplasia, but fortunately within the polyp. And I think it's important to separate the pathology here for polyp versus the lining. And I'll get to that in my next slide. And the remaining lining looked normal. There was no other concerns, and it was sampled independently, and it was benign. So is there a role for conservative management in this young person? So again, the risk of coexisting cancer or progression, pooled estimate. So within a polyp, where you have atypical hyperplasia within a polyp, they have a 5.6% chance of either coexisting cancer or progressing into a cancer. But if it's non-polypoid atypical hyperplasia, meaning coming from the lining, there's a 42% chance. So it's very important to make that distinction, whether it's a polyp versus the lining, because it helps to counsel your patient and obviously to explore alternatives to achieving a family. And even with, attempted conservative therapy within the literature, there are 5 reported deaths of progression of disease while women are being medically managed by progestin. So it's not a benign process, obviously. So what is the success at temporizing? This was a study out of Toronto, actually, by our current fellow. And she reviewed within our database 44 patients, half of which essentially had, back in the terms, the older days, was complex atypical hyperplasia, and the other half, grade 1 endometrial cancer. Median age was like our patient, about 37. And 55% did achieve complete remission over about 6 months' time. And the risk factors that were found where patients did not respond well were the older aged patient, so lower likelihood of remission. And we did see that after 12 months that there's no improvement in the remission rate. So if they're not going to improve in that 6 to 12 month window, or within the 6 to 12 month window, they're unlikely to reverse. So I think at that point it's time to move on. So which way should we give progestins, oral versus local? So this is a comparative cohort, non-randomized, fairly good numbers, 250 with levonorgestrel IUS and 94 oral. A good follow-up, almost 5 years versus about 7 years or so for oral. And they did see a regression rate of about 95% on levonorgestrel and 84%. And we do see progressive improvements in the risk reduction. So it does appear that levonorgestrel is the best choice for women undergoing conservative therapy for atypical hyperplasia or even grade 1 cancer. So what were the sort of consequences? So half of them did recur about 3.5 years in. Half of them eventually underwent hysterectomy. This is not to be overlooked that some of them got upstaged, so now they have to have lymphadenectomy or adjuvant therapy. A quarter did undergo fertility treatments, half no pregnancy, 18%, one live infant, and then a quarter had spontaneous miscarriage. And some of the challenges, how do we monitor this patient during conservative therapy? Do we do hysteroscopy or pipelle? I think based on the literature, especially if you have a Mirena or a levonorgestrel IUS in there, then I think hysteroscopy is the best option for these patients because the false negative rate can be significant. I think it's important to initiate the fertility specialist early to get them involved in the care plan. I think it's important to initiate gyne-oncology referral so that they are on your side, and obviously 55% will move on to needing therapy. And then consider alternate fertility plans, surrogacy, and adoption. This is my last case. So this is a 55-year-old G0 who presented with postmenopausal bleeding. She has class 3 obesity. I just put the obesity scale there just to appreciate that. Her BMI is 57. Adult onset diabetes, hypertension, obstructive sleep apnea. She's had a prior open cholecystectomy, peripheral edema, difficulty lying down for her exam, and she was referred to a gynecologist. So this patient came, in regional care, which you may experience here as well. This patient came from far away to my institution. Took her about 4 weeks. I think bleeding obviously is associated with the fear of cancer and being told that you have cancer, so she did not disclose it until the bleeding became significant, so it took her about a month to see someone. The biopsy, which took some time for the pathologist to come back, took about 4 weeks. She was then sent to what we call a level 1 center, which is a gynecologic oncology center. It took about 3 weeks because she was coming from far away. They reviewed the pathology, took another 2 weeks. That confirmed atypical hyperplasia. They didn't want to deal with it because it's a simple atypical hyperplasia. It should be done by the generalist. So they sent her back into the community to be done. Given her obesity, they tried to find an MIS surgeon. The bottom line is obviously it took a long time from the presentation until she was finally referred to our institution where someone was just going to take hold of her care. And I think this is one of the challenges with managing obesity is patients and physicians and healthcare providers are very anxious about taking these patients on. Anesthetists are nervous, physicians are nervous to take on these cases. And given the duration, the sample was repeated and it had progressed to a grade 1. So obviously there are significant surgical risks, laparoscopy or MIS versus laparotomy. The challenge is obviously it's mainly central or apple-shaped obesity, so all of the adiposity is central as opposed to pear-shaped obesity. So we have to go through all of that. Anesthetic risks, the tolerance of laparoscopy, patient positioning, because we have to operate in the pelvis, unlike our bariatric surgeons who can operate head up. So our anesthetists have a lot of struggles with maintaining that, with metabolic acidosis and things like that. Recovery risks, obviously, wound complications, especially if we do laparotomy, but thrombotic risks are very significant as well. So if we look at obesity itself as a risk factor for endometrial cancer, it's 57% of the population within endometrial cancer can be attributed to obesity. And if we look at endometrial cancer, 70 to 90% of them are already classified as obese. Since 2004, we have seen endometrial cancer risk in Canada grow up gradually, annually by almost 2.5%, and in about 2.5% in the States as well, while other gynecologic malignancies have remained stable. And we do know that a BMI above 25 doubles a woman's risk of endometrial cancer and tripled when she hits a BMI of 30. So, it's a Western problem, but I think you're realizing here as well. I mean, this is not a very well-referenced study, but this is available publicly at the Gazette. And I think Kuwait is now coming to be ranked #1 in terms of obesity rate. Huh? We're not. So, we're seeing, the US used to always be the obese country in the world, but we're seeing with movement of fast food industry and access to all of these things, and, the workforce is changing, obesity is changing. If we look at women itself, right? This is a 2014, I think there was a STEP survey in Kuwait. So it's dated information, but that's the most recent survey that was done. I don't think it was a huge survey. I think it was 4,500 patients or women were evaluated. So, but take it for what it is, right? So 44%, and in Canada we're about 24%. And just to give some merit to it, also from the WHO, Kuwait is coming up there on the map as a red state. So this is a very large prospective study of almost 500,000 women in the States. And we looked at overall cancer death rates for women with a BMI of over 40 and 62% higher than normal weight women. And if we look at the morbidly obese, or the class 3 women, they had a relative risk of death of almost 7, right? It's higher than any other obesity-related cancer. So they also have an increased risk of overall mortality, obviously, diabetes and other dysfunctions. And the issues of ordering an ultrasound as the first test for postmenopausal bleeding can increase wait times by up to 12 weeks just to get the test done and organized. An interesting study called the GOG Lab 2 study looked at specifically women with elevated BMI, and they had a higher all-case mortality, right? So just being heavy, they had a high rate of mortality. And so it's a really important point to counsel these women that that's a huge risk factor for them, not only for endometrial cancer, but just for their general health principles. So I fortunately have access to a surgical robot, and it really does facilitate minimally invasive surgery in obese individuals, reducing their need for laparotomy. If you look at a BMI of greater than 35, there's good evidence to show reduced inpatient time, less bleeding, and fewer complications. And it seems that the greatest advantage is in the really heavy patient of BMI over 50, where the robotic technology seems to be advantageous in terms of reducing wound infection, transfusion rate, blood loss, and shortened length of stay. So what does the robot really provide? The arms of the robot can lift the pannus, so you're not relying on positive intraperitoneal pressure, because obviously when we start pushing the pressure up and having these patients in Trendelenburg, sometimes anesthesia cannot tolerate it. So we can sometimes work at a pressure of 10 millimeters of mercury. So the arms of the robot literally hold the pannus up. The arms can work independently of the arms on the outside, so we can still have all of our dexterity. And at the end of the day, operating on these patients is a challenge. It's very painful for us in terms of our posture and the duration of these cases. And so a happy surgeon generally leads to a happier case. And I think we did see in the era where we're doing a lot of big open laparotomies, we're struggling for vascular control. You can't see very well. These patients sometimes did not do well with big incisions. So the robot really does facilitate that. I think from an institutional perspective, I think it's important to establish a rapid pathway for these patients so that they're not stuck in limbo for many, many weeks. I think it's important to get the oncology centers involved. There's definitely a movement to consider bariatric surgery prior to gynecologic oncology surgery if we can mitigate their symptoms for a period of time, and then really consider the value of a surgical robot in the high BMI patients. So these are my take-home messages. So do not perform routine screening ultrasounds, including the history of tamoxifen use. Refer early. Do not wait for imaging if you're concerned about a cancer or hyperplastic process. Consider hysteroscopic evaluation early and directed biopsy early, as opposed to sonohistograms and waiting another 3 or 4 months to do the tests. Conservative management is an option for fertility preservation or even to defer surgery. So I have a patient's BMI between 60 and 70. We had a BMI patient of 72. So it's very hard to operate on these patients no matter what the robot can do. Right? Anesthesia will just say we're done. And we had a case a few weeks ago where once she was tipped into Trendelenburg, anesthesia couldn't hold her without any gas in her tummy. And so we had to forego the operation. So sometimes we will utilize progestin therapy to get patients into active weight loss management and some of those strategies. Again, if no improvement within 12 months, regression is unlikely, it's time to move on. Obesity must be addressed, I think, during the primary screening, obviously, as a society, and they're given the associated greater risks for gynecologic malignancies, but also all-case mortality. And obesity surgery may be facilitated by the surgical robot. Thank you very much.